Good morning and welcome to our Obesity News Conference being held on day 2 of ENDO 2024 in Boston. Thanks so much to everyone who is joining us, both in the room and online. My name is Jenny Glenn Gingery. I'm the Director of Communications and Media Relations here at the Endocrine Society. Today's news conference, again, will focus on the latest obesity research being presented here at ENDO 2024. We're pleased to have with us Dr. Alexander Turshin, the Director of Quality at the Division of Endocrinology at Brigham and Women's Hospital and Associate Professor of Medicine at Harvard Medical School here in Boston, and Dr. Maria Daniela Hurtado Andrade of the Mayo Clinic in Jacksonville, Florida. Over the next 30 minutes, each speaker is going to present their findings, and then we will end today with a Q&A session. Please note this news conference is being live streamed, so thank you again to those of you who are joining us online. Because we are live streaming, it is extremely important that everyone speak into the microphone so that all remarks can be heard by those who are attending remotely. Journalists, for those of you attending online, you'll be able to type your questions into our chat window at any point, and then we'll get to those in the Q&A. I would now like to invite our first presenter, Dr. Turshin, to speak.
Good morning. It's my pleasure to be here, and thank you all for joining us on a Sunday morning. So I'll share with you our work today on cumulative overweight exposure over time and cardiovascular risk. These are my disclosures. So first, a few words about why we did this study. It's well known that excess weight, overweight, and obesity are linked to a number of long-term health complications down the line, from heart attacks to strokes to cancer and many others. But particularly for heart attack and strokes, the studies done up until now primarily linked excess weight at a given point in time to these long-term complications. And what was not known, and what we wanted to determine, was what matters more, weight at a given point in time or excess weight over a period of time that we thought physiologically might have a greater effect on the long-term sequelae. So the way we did this is that we used data from two large studies, Nurses' Health Study and Health Professionals Follow-Up Study, to analyze their participants' baseline characteristics here prior to 1990, then their exposure to excess weight, which we defined as body mass index over 25 in 1990, so from January 1st, 1990 to December 31st, 1999. And then we looked for incidence of heart attack and stroke in these study participants for up to 20 years after that, beginning on January 1st, 2000. And we specifically looked at individuals who had at least one body mass index greater than 25 during this exposure period in 1990s. And the way we looked at it was what's called area under the curve, as illustrated here on this slide, essentially trying to integrate all the body mass index that's above 25 during that period of time. These are survey-based studies where participants receive surveys about every 2 years, so that's how frequently body mass index was measured in these individuals. And again, these were drawn, participants were from Nurses' Health Study and Health Professionals Follow-Up Study, both funded by the National Institutes of Health. Nurses' Health Study started recruiting in 1970s and Health Professionals Follow-Up Study in 1980s. And they continued, Nurses' Health Study is all women and Health Professionals Follow-Up Study is all men. And they continue to follow their participants to this day. We stratified, meaning analyzed separately, participants by sex and also by age group, as illustrated here. And we also conducted an adjusted analysis that we adjusted for other things that could have been risk factors for heart attacks and strokes, such as smoking history, whether they had diabetes, high blood pressure, or heart disease. or stroke at baseline, etc. Importantly, when we did the adjusted analysis, we also included their body mass index at a starting point prior to 1990, as well as the longitudinal exposure. So this is what we found. So it's a busy table, so I'll just point out a few things. So we had overall over 130,000 participants in this analysis. The majority were women just because of how the NHS and HPFS studies are structured, but there were quite a few men as well. Men were older, and that's also just because of how the participants were recruited in the original studies. These were primarily white participants, again, just because of when and how they were recruited. Now there is a cohort in Nurses' Health study that's more racially and ethnically diverse, but because they didn't have the right follow-up and exposure, we were not able to include them in the analysis. Men were more likely to have heart disease or stroke at baseline. Women were more likely to have diabetes. And men were more likely to have smoked. So this is an illustration of what happened to these participants' body mass index over time during 1990s, our exposure period. Essentially, on average, it gradually went up, though not too much. There were, though, some participants, about 10% in whom it decreased significantly by more than 1 unit of BMI. And this was similar between both women and men. And this is the unadjusted analysis of cardiovascular events of heart attacks and strokes for women. So you can see that the higher the line goes, that means the more heart attacks and strokes they had. And the line that's the lowest, that's individuals in the lowest quartile of longitudinal exposure. Their average BMI over that period of time in 1990s was 25.3, so nearly normal. And the individuals with the highest longitudinal BMI exposure, who had the average BMI of 35, so that's between class 1 and class 2 obesity, had the highest risk of heart attack and stroke in unadjusted analysis. And that, again, was also similar between women on this slide and men on the following slide. And these are the results of the adjusted analysis for various risk factors for heart attack and stroke. So above 1 means that the risk was increased, and below 1 means that the risk was decreased, and blue squares means that the analysis showed that this was a statistically significant relationship, so not likely to have been just random by chance. And we were comparing here participants who were in the highest quartile of longitudinal body mass index excess BMI exposure, so on average 35, to the lowest, on average 25.3. And so you can see here that it differs by age group. So the excess risk for heart attack and stroke was highest in the youngest participants. For women, that's the women younger than 35, and slightly lower for women 35 to 50. And then starting at the age of 50 and older, we could no longer detect an increase in risk in heart attack and stroke with excess longitudinal BMI exposure. I should also note that when we adjusted for everything, so for both baseline body mass index and the longitudinal excess exposure, only the longitudinal exposure remained significant, and the baseline was no longer significant. So the longitudinal exposure was more important. And there was a similar picture for men in the adjusted analysis. We didn't have any data for men younger than 35 just because of how the original studies were structured. But generally, the picture looks the same, that the increase in cardiovascular risk is greater in younger individuals. For men, that included ages 35 through 65. And then men older than 65, we could no longer detect an increase in the risk of heart attack and stroke with excess body mass index exposure. So the conclusions that we draw from this, that excess weight at any given point in time, it's not the final sentence, it's not a done deal, it's a call to action, so to speak. Meaning that what matters is what's done next. And I see that as a glass half full. It means that if somebody has excess weight, there is an opportunity for them, if they lower the weight, to decrease the subsequent risk of these cardiovascular events of heart attack and stroke. And since that excess risk was the greatest in younger people, it seems important to act early in that regard. Finally, I wanted to thank my colleagues, without whom this work would have been impossible, and the funders of our work, and I wanted to thank you for your attention.
Thank you so much, Dr. Turshen. We'd now like to invite Dr. Hurtado Andrade to the podium.
Thank you so much for having me here today. I would like to present about weight trends and predictors of weight gain in breast cancer survivors. And before I go into the presentation, I want to thank my team at the Mayo Clinic, especially Dr. Elif Tama, who has been one of the main supporters for this project. I received research report from the NIH and from Phenomic Sciences, and I am a consultant for Novo Nordisk. That said, the National Institute of Health, Phenomic Sciences, and Novo Nordisk had no participation during this study. I will start with my central finding, which is that in a large cohort of breast cancer survivors, body weight modestly increased roughly by 1.6% during the first 6 years of breast cancer survivorship. Even though the weight gain was modest, 18%, or almost 1 out of 5 breast cancer survivors, experienced weight gain of more than 10% at year 6 after their breast cancer diagnosis. We also found that younger age at breast cancer diagnosis and lower baseline weight were the strongest predictors of weight gain during breast cancer survivorship. Other factors that also put a risk, that increase the risk, include having a BRCA mutation and receiving systemic therapy. Let me tell you a little bit about the background. Why is this important? Well, breast cancer is the most common cancer in women. In 2022, there were 2 million of new cases of breast cancer. In the United States, breast cancer comprises 30% of newly diagnosed cancer cases. It is known that weight gain is a common concern about after breast cancer diagnosis and treatment. And it is also known that breast cancer increases, that the weight gain in breast cancer survivors increases breast cancer recurrence and mortality, increases cardiovascular disease and mortality, and also increases all-cause mortality. And even though it is known that weight gain could happen in breast cancer survivors, the literature is very variable. For example, the incidence of weight gain in the literature varies from 10 to 100%. Weight gain varies from 1 to 6 kilograms over follow-up times of months to years. And studies have failed to conclusively identify risk factors for weight gain. So the aim of this study was to describe weight trends in a large cohort of breast cancer survivors and to identify predictors of weight gain after breast cancer diagnosis and treatment. For this, we used the Mayo Clinic Breast Cancer Registry, which has more than 10,000 survivors. This registry is a very comprehensive registry. In addition to having the demographic characteristics of breast cancer survivors, it also has weights at 1 year prior to breast cancer diagnosis and then at 1, 4, and 6 years after breast cancer diagnosis. And it also contains information about the breast cancer, including staging, treatment, genetics. To better understand weight trends in breast cancer survivors, we compared these trends to a group of age-matched women without a history of any cancer or bariatric surgery. Pretty much a control group of women from the general population. These women were selected from the Rochester Epidemiology Project that links and indexes the medical records of residents in 27 counties in Minnesota and Wisconsin. Let's go over the results. We included 4,575 breast cancer survivors and controls. Cases and controls were mostly white, 97%, and non-Hispanic, 99%. At the time of breast cancer diagnosis, the mean age was 58 years old and the mean weight was 76 kilograms. The controls had the similar characteristics for their baseline weights and age. Most patients in the breast cancer survivor cohort had clinical stage 1, and most had estrogen and progesterone receptor positive breast cancer. Half of patients underwent breast-preserving surgery, most received systemic therapy, and less than a third received radiation therapy. Endocrine therapy was the most common treatment modality when we talk about systemic therapy, and these could have included ovarian suppression, surgical or chemical, selective estrogen receptor modulators, also known as SERMs, and or aromatase inhibitors. And as you can see, only the minority of patients received chemotherapy and targeted systemic therapy. Let's talk about the weight trends in breast cancer survivors. What we see here is the change from baseline to year 1, 4, and 6. So as you can see, during the first year of survivorship, there was a trend for weight loss. This trend was not significant. When we look at year 4 and 6, we start seeing that the weight trend is for weight gain. At year 4, there is a 1.2% increase in body weight, and at year 6, a 1.6% increase in body weight. And these changes in body weight were significant when we compare year 4 and 6 to baseline. How do the trends compare to controls? We actually found that there was a trend for weight gain in non-breast cancer survivors in the control group. And we found that at year 6, breast cancer survivors had gained almost double the amount of weight compared to controls. And again, this is the general trends. When we look at the proportion of patients gaining more than 10% of their body weight, we found that at year 1, 4, and 6, the proportion was higher compared to controls, with breast cancer survivors in blue and the controls in gray. For example, at year 6, 18% of breast cancer survivors gained more than 10% of their baseline weight, compared with 8% of the controls. So we're talking that the proportion of breast cancer survivors gaining more than 10% of their body weight is more than double compared to a control group of women. And there was the same trend for weight gain of more than 15% and 20% from baseline weight. Then we looked at the variables that were associated with more than 10% weight gain at years 4 and 6. And we found that those that were associated with an increased risk of gaining this amount of weight gain include lower baseline weight, younger age at breast cancer diagnosis, more advanced clinical breast cancer stage, having estrogen and progesterone positive breast cancer, having BRCA mutations, having a total mastectomy compared to a breast-preserving surgery, receiving systemic therapy. And when we looked at systemic therapy, the types of therapies that were had an increased risk of gaining more than 10% of their weight include chemotherapy, targeted systemic therapy, and endocrine therapy. And among the different types of endocrine therapies, the two that were significantly correlated with an increased risk were the use of selective estrogen receptor modulators and ovarian suppression. That said, after adjusting for baseline age and weight, because a lot of the type of treatments will depend on the age and menopausal status, we found that age and weight remained the strongest predictors of weight gain. Other predictors included having a BRCA mutation and receiving systemic therapy. In conclusion, breast cancer survivors experienced a modest weight gain during the first years of their survivorship. The weight gain trend in breast cancer survivors was higher than women without breast cancer. Remarkably, almost 20%, or 1 out of 5 breast cancer survivors, experienced more than 10% of weight gain. Younger age and lower weight at breast cancer diagnosis were the strongest predictors of weight gain. Thank you.
Thank you so much, Dr. Hurtado Andrade, for that fascinating presentation. I'll now turn things over to our Senior Communications Manager, Colleen Williams, for the Q&A.
Hi, Regina Schaefer from Helio and Endocrine Today. Dr. Turchin, I had a question for you. Can you speak a little bit more about why the exposure to BMI over time, that risk was greatest for the younger adults? Someone might think it would be the other way around. So why might that be? I know this is speculative, but why might the risk be higher among younger adults?
The short answer is we don't know. And actually, going into it, I would have probably expected, just like you said, the other way around, because older individuals generally have greater risk of heart attack and stroke. So I think this is something that needs to be looked into further. Having said this, other literature that has looked at risks of longitudinal exposure to excess weight for other outcomes, such as cancer and diabetes, found similar effects, that the effect is greater on younger individuals.
Can I ask one more? For Dr. Andrade, what do these findings tell us about how these breast cancer survivors should be managed with respect to their weight and, obesity medications?
Sure. We need to look a little bit better into what additional factors may be playing a role in the weight gain. But these data clearly show that we must consider weight changes in breast cancer survivors, and we must find a way of instituting strategies to mitigate this weight gain. So I'm thinking that for now, given these data, we could consider putting a little bit more emphasis in young women and those who have a lower weight at baseline. Truly, these women have a lot to think of when they have a breast cancer diagnosis. So we also must find ways of instituting these measures in a way that doesn't increase the burden of their health. So a lot of research to do in regards to this, but we must be aware because we need to start thinking that they gain weight. The weight gain is associated with an increased risk of breast cancer, death, and cardiovascular death, which are the first and the second leading causes of death among breast cancer survivors. So we need to start doing that. And the reality is that these women, with the advances in diagnostics, treatments, the great majority of these women are surviving their cancer, but now they are starting to die of cardiovascular disease. There is really no studies assessing the effect of anti-obesity medications in this group of women, and we're thinking that we have started looking into these using the Rochester Epidemiology Project. We don't have any results, but we are hoping to see what is the effect of the use of these medications in this group.
Thank you.
Great. Anyone else in the room have any questions? Okay. We have a couple questions online as well for Dr. Turchin. The first one is, was your study able to evaluate subclinical atherosclerosis, which is known to be asymptomatic, using imaging methods, and would it be beneficial to evaluate it with tests such as carotid Doppler or coronary calcium scoring?
So that's a great question. Our study didn't specifically look at that, and as far as I know, that information is not collected in the studies that Nurses Health Study and Health Professionals Follow-up Study that we used as the source of data in this analysis. But I agree that these investigations of early signs of coronary artery disease and stroke would have been even more sensitive, and so that's probably something that needs to be done next.
Okay, great. That's actually all the questions we have online.
Terrific. Well, thank you so much to everyone who joined us today, both here in Boston and online. We appreciate you attending, and enjoy the rest of your day at ENDO.